Thank you all for coming. Welcome to Phoenix if you're not from here. And for those of you who are residents of Phoenix, what a beautiful city. We're very, very happy to be here. My name is Kathy Costello. I'm the interim CEO for the Consortium of MS Centers, which is the professional group and the professional meeting going on in the Convention Center this week. But I also have a position with Can Do MS in many ways. First of all, Can Do MS is an organization that has always been closest to my heart of any of the MS organizations. How many people here in the room have participated previously in a Can Do MS program? So really quite a few, and thank you for that. Can Do MS is different. There's no doubt about it, and the difference makes Can Do MS very, very special. The mission of the organization is to deliver health and wellness education to help families with MS thrive. What does that mean? It means to live the life that you want. Now, might there be adaptations? Yes, but Can Do MS can help in navigating any adaptations and helping people reach the goals that they have set for themselves. We do that by helping people learn how. How many times have you been told by a healthcare provider that you might want to quit smoking? You probably should exercise more. You should try and get more sleep. You should exercise. You should do this. We should people. Where we fail is in helping people understand how to do these things. We can all know what to do. It's how do I really put this into motion? And I think that's where Can Do MS excels, in not only providing that through healthcare professionals who are our coaches and our group facilitators, but from all of you. Because what we foster is the connection that people have between each other. And I think you're going to feel that today in the program. So More About MS was started a number of years ago by my predecessor at the Consortium of MS Centers, a woman by the name of June Halper. And she felt that if we were bringing healthcare professionals together, we should be bringing people who live with MS and their care partners, we should be bringing them together as well. And a few years back, she invited Can Do MS to run this program. And here we are, and certainly hope that we can continue to offer this program every year. So we have been a pioneer in helping people, and do that based on what you tell us. So we are constantly asking, what is it that people need and how do you want it delivered? And so please, this is your opportunity not only to learn, but to share your voice and your opinion and your needs so that the next programs that Can Do delivers are exactly what you need at that time. In your folder, you'll find information about Can Do MS and a calendar of programs. Also in your folders, you can find copies of the presentation slides from today, a note sheet, and a workshop handout. There's a survey in the folder. This is an important part. Nobody likes to fill out surveys. They're pretty short, but it's really critical for our future programs, and we thank you in advance for completing that. So, and I'll mention this, and it's going to be mentioned again, there are a few bathrooms. The closest one is probably out this door and to your right, and then to your right again, so behind us here. And there's another one, if you feel like you need a walk, across the escalators and then to the left. And that's a lot to remember. I'm sure Stephanie's going to mention that again. And of course, there will always be people outside that can help you navigate and find it. And so with that, I'm going to turn things over to Stephanie Buxhovenen, and she is going to take the program from here. But again, we welcome you and hope that you have a wonderful day. Thank you.
Hi, everyone. It's my honor to be your host today. So first, I just want to tell you a little bit about myself. I live with MS, and every Can Do MS program I take part in or attend, I learn something new. So this is one of my favorite programs, and I'm really excited that you're here. In addition to being an MS patient, I'm also a MS specialized nurse practitioner and full-time MS researcher with the Accelerated Cure Project. If you haven't visited our table, please do. It's right back there. And again, welcome. So a couple of housekeeping. There is one stall, an accessible stall, right out this door by, I think it's like a FedEx office right here. But I would say that your closest bathroom would be going out these doors and to the right. You're among friends, feel free to get up when you need to. We all know how it is. There's also refreshments in the back, coffee, water. Please do whatever it takes to make yourselves comfortable today. And if you are up for it during breaks and during lunch, we really encourage you to mix and mingle with all of our generous sponsors and our exhibitors around the edges. They have some fun swag. Check it out. Yeah, there we go. All right. All right, so first of all, we'd like to thank the Barrow Neurological Institute. They are a comprehensive MS center, meaning they have expertise in multiple disciplines. They can provide a wealth of care for people with MS and their care partners. And so we're really excited and honored to be partnering with them. If you all can give a wave back there. Thank you for being here. And thank you to all of our generous sponsors who really, truly made this day happen. Sanofi, Novartis, TG Therapeutics, Genentech, Biogen, and EMD Serono. Again, go say hi to them during a break. Yes. Awesome. All right, so our plan for the day. So we're here, we're at the welcome. I'm about to bring up Abby for our mindful moment. Then we're gonna start off with a really great talk on MS treatments. Where are we now and where are we going? Then we're gonna take a break, come back and do a little exercising and moving around before lunch. And then we're gonna have a wonderful panel discussion on some of the invisible symptoms of MS, break out into workshops, and then finally have an opportunity to mix and mingle and socialize with each other a little bit. So Abby, would you please come join me up on stage for our mindful moment?
Good morning, everyone, and thank you so much for being here. We'd like to start the day to just ground ourselves in the moment and practice some brief mindfulness. For those in the room who've practiced mindfulness before, maybe through a can-do program or on your own practice, can you raise your hand? Wonderful. All right, so some folks who've already maybe been practicing regularly, and for those who haven't, this may be something new for you. I just want to invite you to fully participate in today's program. Participation is a key part of mindfulness. We try to focus on doing one thing at a time and fully participating as much as we can so that you can do what you can to get the most out of the program. I invite you all to get comfortable in your seat with your feet on the floor or on your chair, whatever's most comfortable for you. Feel free to take some breaths, just some gentle breaths in through the nose and out through the mouth, just allowing ourselves to settle into the moment. If you'd like, you can let your eyes gently close or settle on a spot on the table or the floor in front of you. And as we take some breaths in, slowly count to yourself to about a count of 4, in and out. Just noticing your breath as it gently comes in and out. If you notice different sensations in your body, just acknowledge them and let that thought pass through your mind as you refocus on your breath in and out. You may notice your breath slowing and now becoming more regular. And I invite you to bring to your mind something that you can do, that you feel proud of, grateful for, something that brings you joy or success in your daily life. This could be something you do for work, something in your relationships, something personal in your self-care, whether you're a person living with MS or a care partner or a support partner or a healthcare provider. Something that you feel proud that you can do as you continue to breathe in and out. Notice if that thought brings a gentle smile to your face, allowing the corners of your lips to turn upward. Breathing in and out. And as we take some of these breaths together, ready for the day, I invite you to bring in some energy for our first speaker, bringing to mind that can-do spirit and attitude for what you can do in your personal goals. Thank you so much, and we'll go ahead and start the day.
Thank you, Abby. It's always such a great way to start a program. So I'm very pleased to introduce our first speaker for the day, Dr. Michael Robers. He is a MS specialized neurologist and an assistant professor of neurology at the Barrow Neurological Institute. His research focuses on disparities in MS as well as clinical trials that address new treatments for MS, and he's going to talk to us about what therapies currently exist and what's on the horizon. So welcome, Dr. Robers.
So we're going to talk about MS treatments, where are we now, but hopefully we're also going to talk a little bit about where we're going in the future and where we have been to understand where we're going. And so a couple of learning objectives. So we're going to review the history of MS disease modifying treatments. We're going to understand the current treatment practices, celebrate the advancements that those represent and that we've made in MS treatments, but we're also going to acknowledge the shortcomings of current MS treatments. We're going to discuss updates in our understanding of MS pathology, and then we're going to discuss the future directions of MS care based on our new understandings. And so, does anyone recognize this chair? It's in the Smithsonian Museum, if anyone has been there. So this is the chair that George Washington sat in while he served as the president of the Constitutional Congress as the United States, as we now know it, was formed. And Benjamin Franklin had a famous quote about this chair, and he says, "I have often looked at that behind the president without being able to tell whether it was a rising or setting sun," is what he's referring to, that engraved sun that's only half the sun. "But now," this is at the quote at the end of the conference, "I know that it is a rising sun." And this is relevant for today because that's what it often feels like to be involved in MS care today. Right? We often, recognizing the shortcomings and the difficulties that people living with MS have, can feel like it might be a setting sun, but I hope to convince all of you by the end of this talk that this is, in fact, a rising sun in the care of MS. To understand that rising sun, we have to understand a little bit of where we came from. And so this is a timeline of treatments that changed the course of multiple sclerosis. And you see, before 1993, there were no treatments for multiple sclerosis that actually changed the course. And then when they first came out with interferons, there was such a limited manufacturing capability. Some of you may actually remember or have experienced there was a literal lottery to be allowed to be treated for multiple sclerosis. And then we have had a rising progression of FDA-approved treatments, which actually changed the course of MS. And as you can see, now we have, on the screen is not even fully complete, so we have over 20 treatments that can be used and decided from. And while each of these are spaced out evenly so that you can read the names, if you look at the years, what you'll see is that they're getting closer and closer together, right? So initially, from 1993, it was a couple of years before it, and it was one at a time, very slowly. And towards the middle to end of this slide, you see the years getting closer and closer together, where there's multiple medications being released in the same year, multiple medications being released within a couple of years. And so our choices are rapidly expanding in terms of how we treat MS. And that can be a huge discussion, right? How do I talk about 20 different treatments in someone who I'm supposed to see in a 15-minute or 30-minute appointment, right? Well, the real answer is we don't. We just go over time. But there are ways to categorize these and think about that. And so thinking about where we are right now, these are all long-term treatments. We're not talking about what happens when someone has a relapse or when someone's in the hospital. We're talking about things that we use long-term over years and decades to reduce disability. And that can be changed over the course for how we treat it. So according to the FDA, some of these medications are approved for relapsing remitting multiple sclerosis, and that's the vast majority of these medications that are approved. And then we do have a couple of medications that were approved specifically for progressive multiple sclerosis. So in 2017, ocrelizumab was approved for primary progressive multiple sclerosis, and then before that, in 2000, mitoxantrone was approved for secondary progressive multiple sclerosis, although that's since fallen out of favor because of toxicities. And then in 2019, siponimod was approved for the treatment of secondary progressive multiple sclerosis. There is a little bit of a caveat to that, in that it was approved specifically for what we call active secondary progressive multiple sclerosis. And when the FDA looked at the data that they submitted, they actually kind of added this, maybe everything for secondary progressive multiple sclerosis. And they actually retrospectively approved almost all of the other relapsing remitting multiple sclerosis treatments for active secondary progressive MS. And so this landscape is rapidly expanding in how we think about it, and thinking relapsing remitting MS treatments versus progressive MS treatments may be becoming outdated even. So what are some other ways to think about these different medications? Well, we can think about them in terms of efficacy. And so when we talk about efficacy as MS specialists, we're talking about how much do we reduce relapses or new lesions on the brain, new inflammation that's ongoing. And so we can categorize those in terms of kind of a low efficacy group, which is about 30% reductions in relapses. And those include all of the interferons, glutarimer acetate, as well as teriflunomide are in that range. And in general, all of these medications, while they will argue about the differences of their mechanism of action at a molecular level, do something similar. They are treating an autoimmune disease that is believed to be a result of your immune system being too active, and they are trying to modulate and lower the activity of your immune system to some extent. And some treatments do that by a little bit, and therefore they're going to reduce these relapses and inflammatory events by a little bit. And then there are medications that do that more and are going to have more effect on the immune system, more effect on preventing relapses. And so moving up into kind of medium efficacy medications, we have the fumarates, which are now a class of medications that have multiple different medications within them: dimethyl fumarate, monomethyl fumarate, diroximel fumarate. And those are pills, as well as the S1P inhibitors, which are, again, multiple different medications: fingolimod, siponimod, ozanimod, ponesimod. And they work in slightly different mechanisms of action, which we don't need to go into detail, but those are discussions that can be had with specialists in the clinic in terms of what mechanism might be best for one individual. There is some debate as to kind of where some of these medications fit, but this is kind of the current thought process of where these medications fit. And where I'm drawing the line for high efficacy then is these medications. So cladribine, which when you look at relapse reduction, is a little bit higher than that last group, but in the group that we kind of drew the line at the 70 to 90% reduction in relapses as compared to 50% in the last slide, or 30% before that. And then there's natalizumab, and then there are a group of B-cell depleters, which are getting into true immunosuppressants that are killing off some of your cells. And then alemtuzumab, which is a very significant medication that kind of wipes out significant parts of your immune system. All of these are medications that very highly prevent relapses and very highly prevent disability from relapses. And we can also think of these in how we give medications, right? So some of these are injectables, some of these are pills, some of these are infusions. And when these medications first came out, there was a kind of thought process, so the injections were the first medications to come out. Interferons were all injections, glutathione acetate followed with an injection. Then some of the oral medications, and then infusions. And the infusions that first came out were all the high efficacy medications. So there was this kind of common thought process, oh, the injections are the low efficacy and the infusions are the high efficacy. I feel the need to point out that that's no longer true. There are pills that are considered high efficacy. There are B-cell depleters that are high efficacy that are now self-injections at home. And so the concept of whether you're injecting or taking a pill or taking an IV infusion is no longer indicative of whether or not you're taking a high efficacy or low efficacy medication. It really is about meeting the patient where they are and what the best treatment and most convenient form of treatment is for them. And so all this results in this, right? And there's so many medications, so many ways we can divide them by their mechanism of action, by their efficacy, by how you take them, by the convenience for the patient. It can be very much information overload. So I wanted to get a slide here that just kind of describes where we are and how all of this information that I very quickly went through really results in the current care and the more recent care of MS therapy. And so this is an individualized therapy. And I don't know if I have a, you guys still hear me? Okay. I don't know that I have a laser pointer, so I'm just gonna walk over here and we're gonna point and shout. So now we have kind of personalized therapy based on how someone is diagnosed, whether or not they may have just had an MRI that might be MS, but they've never had symptoms, they're not formally diagnosed. Some people are still choosing not to be on medication, although more and more they're being advised to be on medication. And then once they're formally diagnosed and they definitely have MS, there's kind of categories that we can go through. And there's people who, for their personal preferences as well as their provider's instinct in terms of how they're going to do, how aggressive their disease is, might do well on low-risk medications, don't have a lot of risk of infections, maybe less side effects, very convenient for them. And then there are other patients who have very aggressive disease right from the onset or have already failed one of these diseases and they kind of step up. And that's what you may hear of step therapy, being that many people start on some of those lower efficacy medications and then move up. But we do have markers in MRI, markers in how patients do in the hospital or in the clinic that say, hey, this person should skip that first step and be right up on high efficacy medication. And so there's a broad range of how people are being treated currently in terms of choosing where it is, and it's getting to the point of being a truly personalized conversation between a patient and their doctor. And that's a really good place to be, but it is somewhat incomplete. And so what have we actually achieved since the 90s, which is now more than 30 years ago, right? The 90s were 10 years ago, and they're always going to be 10 years ago for me, right? But now, when I teach at Creighton University, my medical students were born after disease-modifying treatment for multiple sclerosis, right? They do not know of an age where MS was not treatable. And so what have we really achieved here? And we've achieved great things. So we have medications now in these disease-modifying therapies that are proven to reduce relapses, proven to reduce the conversion of clinically isolated syndrome to clinically definite multiple sclerosis. And clinically isolated syndrome was a category of those individuals who have had one attack, were concerned that they have MS, but they don't formally meet all the diagnostic criteria. And if we put those people on treatment, we actually prevent them from becoming definite MS and reduce their likelihood that that's going to happen. When someone has relapsing remitting multiple sclerosis, we can stop them from having relapses. So if someone hits our clinic today after their first attack, we can, with a straight face, tell them, we can prevent you from having another relapse period. And then we know that by preventing new lesions on the MRI, we can prevent that. Your MRI can stay the same for decades now. And we can keep your MRI looking the same and keep you from having relapses. And by doing that, we can now reduce your disability over time. And that's been proven. By being on these medications, by being treated for MS, over time, we reduce future disability. And we do that by so much that based on some nationalized databases out of Europe where they watch all of their MS patients because they all have access to the same care, they have shown that as the generations of treatment of MS have advanced, the rates of secondary progressive multiple sclerosis are actually reducing. And so when we define as secondary progressive multiple sclerosis as those people who used to have relapsing remitting MS, they used to have relapses, get worse, get some steroids, get a little better, and have that happen over and over again. But then eventually they just kind of start slowly getting worse over time without any relapses. It's not falling off a cliff and then getting better anymore. It's not having new lesions on MRI, but it's just slowly getting worse over time. That used to happen to about 50% of people who were diagnosed with relapsing remitting multiple sclerosis. That went down with the first generation of treatments, and after the second generation and the high efficacy treatments came onto board, these large registries are saying that that's closer to 20%. And so we are actually reducing the number of people who even experience progressive MS with these treatments. And we should note that that's all done by addressing one pathophysiology, and that is the anti-inflammation. All of these medications, again, treating an autoimmune disease by reducing your immune system. So maybe just taking a moment to feel like we're at the top of the mountain, like that's a rising sun on that chair, of all the great things that we are doing for multiple sclerosis. But what's missing from treatment, right? I think most of us sitting in this room, while we would all love to cheer and clap about all the successes that we've had, know intuitively by knowing someone with MS that we don't have a cure, that we haven't fixed all of the problems, that it's not just an easy disease to have. So what are we missing? Well, I talked about that person who came in after their first relapse, and I can tell them that I can keep their MRI exactly the same and I can prevent them from having relapses, and that's going to prevent them from having future disability. But what I can't do is fix what they come in with already, right? That first attack, that first 2 attacks that took them to get diagnosed, now they have disability that's already there. They have some vision loss, they have some numbness, they have some weakness, they have some bowel bladder changes. Those things we don't have a fix for in terms of remyelinating. There are symptomatic treatments that can help quality of life. But in terms of saying, hey, there's that damage in your MRI, and we're going to put something there that's going to actually fix that damage, and you're going to feel like that attack never happened, we don't have that. We also, when we measure MRI metrics of multiple sclerosis, what I mostly was talking about for the last couple of minutes is lesions, right? These scars that we see on the MRI that represent inflammation in the brain. Those we can stabilize, but not get rid of. But MS is more than that. MS also has what we call atrophy. Everybody's brain actually naturally gets smaller as we get older. It's happening to me already. It's happening to most of the people in this room. But that rate of slowly getting smaller in your brain, that atrophy, is higher in people with multiple sclerosis than it is with the general population. And these medications, before the companies jump down my throat, there is individual data in some medications, but as a whole, we do a poor job of treating atrophy in MS. And we have limited benefit in progressive MS, whether it's primary progressive or secondary progressive. We are preventing secondary progressive MS, like I just mentioned, but once someone has secondary progressive MS, we have no great treatments for that. But Dr. Roberts, you just said everything's FDA approved for secondary progressive MS. Why are we having all these medications that are supposedly approved when you're saying that none of them actually treat? So let's talk about that. We are now getting to the point we are changing our understanding of the pathophysiology of multiple sclerosis. This is what everybody has been taught for years. This is what I was taught in medical school, that there were different classifications of MS and there's these different silos, right? There's relapsing, remitting MS. I'm going to walk back over here. So in that top left, or your top left, We have these big squares of going up, and what the y-axis, the vertical part of these graphs, are supposed to be disability, and the horizontal x-axis is supposed to be time. And with relapsing remitting, you had these people who have these episodes of disability and then getting better, which may completely get better, as you see in that top little square, or leave some permanent disability in individuals who are there. And then we had secondary progressive MS in that top right corner, which had those relapses, but then just slowly started getting worse. And then we had primary progressive, which is someone who's never had relapses and is just slowly getting worse. And then they even threw in this progressive relapsing that started like primary progressive, but then maybe had 1 or 2 relapses in their course. And then we started talking about something called translational progressive, which is a single relapse and then progression. And we were getting all of these silos and trying to parse out every single individual. But the reality is that when we actually learn about the pathology of multiple sclerosis, all of this is wrong. Everything I've been taught is wrong. Everything everyone has been taught is wrong. And it's good that we know that, because this is now a better understanding of what MS is. It is one disease. It is not 4, 5, 6 diseases. It is one disease that treats people differently. And it can happen before anyone ever has a symptom. So in this graph, we still have that disability on that y-axis going up vertically, and then time on the x-axis. And before someone ever has symptoms, this dotted line that says clinical threshold. Anything that is below that dotted line means someone had no symptoms. Anything above that dotted line means that they're having symptoms from that part of the graph. With the exception of the red line is brain volume, and so that crosses the clinical threshold more the other way around, and that's going the opposite direction. So you can have what we call radiologically isolated syndrome, where you get lesions, get scars on your MRI, but never have a symptom. Now, with the 2024 diagnostic criteria, we can actually diagnose those people with MS if they meet specific criteria and get them on treatment before they've ever had a symptom. Then someone might have that clinically isolated syndrome, one attack, but maybe not meeting all the criteria, or they might have multiple relapses and be relapsing remitting MS. But even if they have radiologically isolated syndrome, clinically isolated syndrome, or relapsing remitting MS, we see right from the beginning, the beginnings of progressive MS with that brain volume already coming down at a rate that's faster than the general population. And slowly, we start to see additive damage in this dotted red line with axonal loss, which is the actual body of the nerve as opposed to just the coating of the nerve that is myelin, slowly getting more and more damaged. And eventually, those can result in this progressive disease where a secondary progressive course that's after relapses or a primary progressive course that did not have relapses run exactly in parallel together and represent the same pathophysiology that's occurring. And so when we think about this, we are now getting to the point where we're talking about pathophysiology. We're talking about what's happening in the brain. So what's different? There are 2 things that are occurring here. What's different between the bars that are coming up and going down and the lines that are just slowly getting worse with atrophy, slowly getting worse with disability? Well, now we know that there are actually different things occurring. So there is inflammation, where your immune system, if you have MS, is getting confused, is flooding from the outside into the inside of your brain, causing new scars and attacking your brain. And then there's what's being billed by certain people as smoldering MS, or some people are saying degenerative MS, or some people are saying compartmentalized MS, where it's these cells that are supposed to be in your brain. They're supposed to be living there. They're supposed to be taking care of your brain that are there. It's not an invasion from the outside. It's not B and T cells and your immune system flooding in. It's these little support cells that are always supposed to be there, cleaning up the brain, making sure everything is working functionally. And they're just slowly causing more damage over time. And that results in that slow enlargement of some lesions, even if there's no new lesions. That results in slow loss of brain tissue and that increased atrophy. And that likely, in our current understanding, represents a true cause of that slow worsening without relapses when we talk about progressive MS. And how do we know this is true, and how does it actually affect why I say we treat relapsing MS really well, but not progressive MS really well? Well, we're going to talk about some treatments, and full disclosure, this is not an FDA-approved treatment for multiple sclerosis, but we're going to talk about the history of getting a treatment for primary progressive MS. And what we're going to talk about is how these clinical trial data actually tell us that there's different pathophysiology occurring. And we're going to call it inflammation, or active MS, or inactive MS, meaning no inflammation. And so this is the original readout data of a clinical trial of a medication called rituximab, which is a B-cell depleter. It kills off your B cells in primary progressive MS. And they took all of the individuals that they could find with primary progressive MS, and they randomized them to receive treatment or no treatment, and saw how they did, hoping that this would change the course. And the answer was that it didn't. The overall results of disability did not improve in this trial. But when they looked, so that's that top, the all patients, there was no difference between those lines when they actually judged, is this actually significant, and saying that there's a cause from this medication. But when they looked at subgroups, the young people, and meaning under the age of 51, and the people with what we call gadolinium enhancing lesions, which is evidence of new inflammatory lesions, those people actually did better when they got the treatment versus those people who did not get the treatment. The young people with inflammation were benefited by rituximab. The people over 51 who didn't have any changes on their MRI were not. And so this was, people actually cried at the results of these at the clinical longest standing ovation at multiple different clinical trials, the first treatment FDA approved for primary progressive MS. And this shows a significant benefit in the time to disability in people with primary progressive MS who were treated with ocrelizumab, which is also a B-cell depleter, compared to people who didn't receive treatment. Why didn't rituximab work, and why did ocrelizumab clinical trial work and everyone cry and clap and everything? Well, who did they recruit to the clinical trial? They recruited, anyone want to take a guess? Based on that last slide? They recruited younger people who had inflammation, right? So what we really know is that active inflammatory primary progressive MS is benefited by ocrelizumab. Inactive, non-inflammatory primary progressive MS may not be. Not to pick just on one company or one drug, the same thing is happening in secondary progressive MS, right? So S1P inhibitors are a class that have differences amongst them, but they all work on the same receptor in different subtypes. And multiple medications have been tested, and previously, a precursor to this medication, fingolimod, which was the first S1P, did have a secondary progressive trial that was completely negative, did not help secondary progressive MS. But when we did a trial with the siponimod, specifically in secondary progressive MS, it did show benefit. It delayed the time to onset of disability in people who had secondary progressive MS. But when we look at the small details of this trial, you're going to see a very similar theme coming on here. So in the top section where you see these lines separate, that's saying that there is a difference in disability compared to the placebo on this medication. But when we start to look at now individual subsets of people, there were individuals that seemed to benefit more than other subgroups. And when they looked at those subgroups, it was the ones that had lots of benefit were the ones that also had relapses, superimposed relapses in the 2 years before. the treatment. And it was also the younger people who had enhancing lesions and who had inflammation. So in primary progressive and in secondary progressive, while you can get into the weeds of these clinical trials, the message is for active inflammatory multiple sclerosis, regardless of whether you have relapsing disease, primary progressive disease, or secondary progressive disease, these drugs work. They prevent disability. But if you don't have inflammation, if you have that inactive MS that's slowly worsening with the MRI looking the same, we're not doing it. When we look at treatment with high versus low efficacy medication, this was done in more of a real-world retrospective database. And they showed that high efficacy medications reduced relapses in active secondary progressive MS. And so what that means is, again, it's all one disease. People who were labeled as secondary progressive MS were still having relapses, and that's how these medications were really helping them, by reducing those relapses. And there was no difference in inactive, non-inflammatory secondary progressive MS. And so the big picture of what I'm trying to tell you is, while we had the picture of the person kind of at the big lake on the mountaintop, we do have that for not relapsing, remitting, or primary progressive, or secondary progressive, for inflammation. Let's talk about pathophysiology instead of just what someone experiences. And when it comes to inflammation in MS, we are at the mountaintop or near the mountaintop. We can stop inflammation in MS, and that's awesome. But when it comes to the other causes of progression, we're a little bit more like Sisyphus, pushing the boulder up the mountain, and it's only going to roll back down when we get our hopes up. So how do we move forward from here? How do we go from, hey, we treat inflammation really well, and I can stop people from getting secondary progressive MS, I can stop people from getting new disability or new lesions, but once they have that progressive disease, we don't have a whole lot to offer. How do we get that rock to stay at the mountaintop? Well, first we have to understand what's actually causing this progression. And for many years, the real answer is that. Also, again, showing my age, I saw a recent thing that little girl's like out of college now. There are multiple different hypotheses as to why someone has progression. And investigating and understanding why progressive MS doesn't respond to inflammatory medications is going to help us find new medications. And so I'm going to go through several different hypotheses, and then we're going to talk about what the future of each of those hypotheses are and how we're actually going to move forward, and why, even in progressive MS, that chair that I showed you at the beginning of the talk is in fact a rising sun. So the first hypothesis I want to talk about is from Stephen Krieger, who's at Mount Sinai, who's a great clinician educator and scientist in MS. And his hypothesis of progressive MS is that the like symptom recrudescence, also can be referred to as Uthoff phenomenon, or pseudo-exacerbations or pseudo-flares, where people get worse when they get sick, get worse when they get overheated, get worse when they're not feeling well, but then get better, and their MRIs are the same, there's no new lesions, there's no new damage, they just weren't adapting well to that extra insult from overheating and infection or stress. Just like that, that progression clinically recapitulates prior relapse symptoms and unmasks previously silent lesions, revealing underlying lesion topography. And so his hypothesis is that if you have these underlying lesions on your MRI, and maybe when you're 20, you have no symptoms from those lesions, that doesn't mean that you won't have symptoms from those very same symptoms when you're 30, 40, 50, 60, 70. It's kind of like rolling your ankle, right? You roll your ankle when you're a teenager, you get up, you keep running, nobody even looks at you second. Roll your ankle when you're in your 20s, maybe you kind of laugh at it at the bar with your friends and you're limping the next week, but next season when that sign up comes for that activity, you go ahead and do it again. Roll your ankle badly in your 30s, you're kind of like, yeah, I'm done with that. Roll your ankle in your 50s, you might never walk the same. Right? The same thing is happening in our brains. And so this has a great video that we're going to hopefully work. And we're going to take you through this. So this is two things. There's a pool full of water. And over time, you have these inflammatory attacks that occur. And if they cross the water, they give you symptoms. But up high in your brain where you have lots of deep water of neurologic reserve, it's hard to cause symptoms. Lower down in your brain, your spinal cord, you might get symptoms. But those spikes reduce and maybe don't have symptoms. But now as you age, you're starting to realize that water is actually draining. The pool is slowly draining, and all of those little water mines of lesions that are in the brain and spinal cord all of a sudden are being revealed as that water is draining. And that is a good video representation of the two different pathophysiologies that we now know are occurring in MS. We have the large episodes of inflammation that represents those spikes, those little water mines, if you will. And then there's something that's leading to the pool draining. And as you drain that pool, those old lesions come up. And this hypothesis makes a lot of sense in what I just said about the European data saying we're reducing the rates of secondary progressive MS, right? Because if you stop the formation of these lesions, when the pool drains, there's less lesions to cause new symptoms. And so what are we actually doing about what is the data that actually supports this? So he actually took data of people who were first diagnosed with secondary progressive MS, found the date that they said, okay, in retrospect, this is when we think they first had progressive symptoms. And they went through all of their exams before that date. And when they did that, the first secondary progressive symptoms were old relapse symptoms in 83% of patients, and a higher rate if you included symptoms that had occurred at any time. And so the response to how do we treat this hypothesis of secondary progressive MS is what we're already doing, right? The earlier we can get people on high-efficacy medications that prevent these lesions and stop these lesions from forming, the less and less disability we'll have in secondary progressive MS. But that's not the only thing that might be causing progressive MS. There's also now what's being called smoldering inflammation, and while I highlighted Stephen Krieger at the last slide, he would be angry at me for using smoldering inflammation. Different people like different terms for this, but this is that slow damage to the brain from cells that already live there, whether it's degenerative or compartmentalized inflammation or smoldering. This is different than the active inflammation. And we know that progressive MS is less likely to show blood-brain barrier disruption through gadolinium on MRIs. And we know that while new T2 lesions are very rare in these progressive patients, some of these lesions slowly get bigger and slowly expand. And so that is kind of where that term smoldering comes in, like the embers of a fire slowly eating the log as opposed to the big flames. And we know that microglia and macrophages, which are those cells that live there, are seen along with this demyelinating pathology when we take biopsies or when people donate their brains. And we can actually see some of these cells that live there causing some of this damage. On really high-powered MRIs, we can see that these slowly expanding lesions are associated with other markers of damage. And then we can see that there is compartmentalized inflammation along the coatings of the brain, the leptomeninges, that are not necessarily well treated by our current overall anti-inflammatory medication. So there is evidence that there's ongoing compartmentalized smoldering inflammation. And then there's also degeneration. We talked about not everything about the volume loss in the brain may be directly related to inflammation. There may be a completely different pathology occurring that's leading to these brain volume loss there. And that we know that there's increased loss of the actual nerve damage, there's increased atrophy beyond what we see related to inflammation. And one hypothesis of that is that that's caused by oxidative stress. And so oxidative stress is a topic that occurs throughout our bodies, but now we're understanding more of it in our brains. Free radicals are molecules that have an extra electron that are ready to oxidize things around them. They lead to production of increase in production in active MS lesions. So there's a link between inflammatory MS lesions and these free radicals and oxidative stress. And we know that oxidative stress and these free radicals disrupt the energy production in your body and in your brain as well. And that can reduce these. And the oligodendrocytes, big fancy word for the cells that are living in your brain that actually play a role in kind of myelin formation and creating the myelin that is attacked in multiple sclerosis, are highly sensitive to oxidative stress. And so these cells may actually be dysfunctioning because of increased oxidative stress. We also know that once a lesion forms in your brain, those neurons that have demyelination, where that coating is damaged, have increased energy reserves. So not only are your oligodendrocytes affected by oxidative stress, you're increasing the amount of oxidative stress because there's increased energy demands when you don't have functioning myelin. And that may actually lead to an increase in apoptotic signaling. What is apoptotic signaling? That's basically programmed cell death. Everybody's cells are designed to only last so long in their body, and they get replaced by other cells. And we may actually have increased signaling of, okay, this neuron, this nerve has reached at the end of its lifespan. It needs to be trimmed, and these cells can go ahead and be eliminated sooner than they should because of this oxidative stress, and that could directly correlate to that brain atrophy. So now we have kind of 3 different hypotheses of why people have progressive MS. So where are we going? What do we do with all of this new understanding? Now we know it's one disease. There's multiple different types of pathophysiology, inflammation, not inflammation. We know we treat inflammation really, really well. We know we treat not inflammation not very well. So how are we going to go through all of these curved roads to find our way out of here? Well, for that first one I already mentioned, we are changing the way we're thinking. So I talked about how we're doing lots of individualized medicine, and maybe some people might choose to be on low efficacy medications if they're low risk and high efficacy if they're high risk for high disease. Well, we might be changing that soon because the newest data coming out is saying preventing relapses is really, really important to preventing the recrudescence of the topographic hypothesis of progressive MS. And we are showing that if you take all comers, these are observational data that I'm presenting right here that have been published, show that people who were started early on high efficacy therapies actually did better over the years than people who were not started on high efficacy therapy and went through that step therapy. And this is more data showing the same thing, that basically if you are started on high efficacy therapy right away, that there's less lesion formation, there's less disability formation than people who go through that starting on low efficacy and working their way up. But what actually is high efficacy therapy is still a question. And so different things. So on your left is a scatter plot from an observational study looking at relative efficacy of different medications. And they actually found that basically anything beyond S1P inhibitors, so S1P inhibitors, that fingolimod, siponimod, ozanimod, ponesimod, or natalizumab or B-cell depletion were all high efficacy therapy. That was before cladribine, which was the other thing I had put in the beginning of my slide as high efficacy, was FDA approved, so it's not in that study. Interestingly, a different study on your right is showing a significant difference between natalizumab and fingolimod in real-world data. And so where exactly we draw that line, different people are drawing different things. And we are a part of one of the clinical trials. There are 2 nationwide clinical trials occurring, actually trying to test this and really show, okay, if we randomize people to high efficacy or standard of care efficacy therapies, they get to choose which medication is right for them within those groups, and then we follow them over time, who actually does better. We're gonna have those answers of whether it's actually the right answer to put everybody on high efficacy therapy right away, or if the more personalized approach is actually better. So we'll have real answers as to which one of those is correct coming up in the next several years. And targeting the pathology of topographic recrudescence, we can, again, reduce secondary progressive MS. Then, and again, I actually already talked about this. This is that slide proving natural history, 50%, newer data, 20, 25% secondary progressive MS. So we are actually changing that topographic model of MS as we speak. And maybe some of the most exciting data that's come out in MS recently is now we have some evidence that we're actually targeting smoldering. So that smoldering MS that I said isn't inflammation, that inactive secondary progressive MS in 2024, the top-line data was released, and just this April, the actual publication was released. There are now medications that, while only by a little bit, are actually preventing and delaying disability in people not with inflammatory active secondary progressive MS, but in truly inactive secondary progressive MS. And when we look at that, it's actually the subset of individuals who are most helped are not the individuals who had enhancing inflammatory lesions, but are actually the people who had evidence of slow progressive smoldering MS, something we call paramagnetic rims, which is what we see on MRI when it's this slowly enlarging lesion. How are we targeting underlying pathophysiology of the degeneration? Well, there's early medications, nothing that's going to be FDA approved soon, but there are early studies and medications in the past several years that showed improvement in brain atrophy and disability. But in that early small study, the overall brain atrophy was much lower than expected, and so there may be something special about that group that doesn't necessarily pan out. Many times we have gotten our hopes up about things. So we have to be cautious when we talk about these early studies, but there is evidence that there might be medications that might actually identify a difference in this kind of degenerative course. Remyelination, there's whole topics at all of these conferences. Across the street yesterday, across the street today, there are people talking about basic science medications that might help remyelinate. Most recently, there was some data about a type of stem cell therapy, which patients always love to talk about, so I love putting these slides in here saying, hey, I know what you guys want to hear. And it, just in a small group of 48 patients, showed some possible benefit. And they are actually trying to target these stem cells to create oligodendrocytes and create myelin. And then there are all other medications that are being studied in labs, in mice, that might actually lead to remyelination in the future. I talked about stem cells briefly. Just remember, there are 3 types of stem cell therapies. So when we talk about stem cell therapies, there are charlatans who are trying to take your money and not going to help you. And then there are autologous hematopoietic stem cell transplants, which we know work in inflammatory MS. They're something similar to all of our anti-inflammatory disease-modifying therapies, high risk, high reward. We don't know if those work better than our high efficacy FDA-approved medications. There are some ongoing studies trying to answer that, and it might not be that they work any better, but they do work somewhat. And then there's these mesenchymal stem cells where they're trying to target repair. And those are only really research-driven right now, but there is a thought process that those are different. So if you're talking and asking questions about what is the state of stem cell therapy in MS, know that there are truly two different types of stem cells, and their state of evidence is different. So oxidative stress, there's also very early data in different supplements and other medications in alpha lipoic acid. There's some early study that says it might help with brain atrophy. We know, and my area of special interest revolves around comorbidities. We know people who have comorbidities like diabetes or high blood pressure actually do worse with MS if they have both diseases compared to if they just have MS alone. And that's led to studies looking at treatments for those diseases. And so metformin is a treatment for diabetes, and that's been recently studied, a very small number of people who had obesity and had metabolic disorder, that they actually showed less inflammatory changes when they were treated with metformin for that. And so there is early hope that those treatments will actually help MS directly. But again, lesson learned, these early treatments are just hope on the horizon. We had that same hope about biotin, which is a hair and nails at very high supplement at very high doses. It was being billed as an actual treatment for progressive MS. A single center study showed it had significant benefit. We ran a huge phase 3 clinical trial trying to prove it, and it did not work. So we have to wait. I'm not recommending starting any of these medications or on these slides or talking to your doctor about being on any of these. I'm just saying that there's hope on the horizon scientifically. And talking about hope on the horizon scientifically, my last message is how do we actually participate? This isn't just about me being up here talking about clinical trials or the industry in the back talking about their clinical trials. Research is hands-on, driven by patients. The questions that are driven by what's important to patients, and we also need patient participation for these things. So these are ongoing clinical trials that I just pulled from www.clinicaltrials.gov, which is ongoing clinical trials in the US are required to register there, and they tell you whether they're recruiting or whether they're not recruiting. So anyone interested in participating or just seeing what's out there and what the next best thing is, this is all publicly available information. It's not a secret in industry or a secret at your doctor's office. And we're doing lots of clinical trials looking at high efficacy therapy, looking at phase 3 coming up for that ibutylast, which was that early degenerative disease that's actually recruiting more and more people in Europe. We have ongoing clinical trials in progressive MS, looking at a wide range of medications, as well as looking at a kind of comparative trials, actually looking at, now that we have primary progressive MS, ocrelizumab, there's a clinical trial looking at that compared to a newer medications. We're gonna have more and more understanding of what helps and what doesn't help. We have ongoing clinical trials available in remyelination and repair. So getting back to the big picture as I get close to winding up, I know I look like I could keep talking forever, but I promise this talk will end. We're doing really well at inflammation. We're not doing great at inactive MS, but we have lots of hope and a sun rising even in inactive progressive MS, and we are going to continue to improve how we treat MS throughout the future. And I think that this is really a great time to be treating MS and a hopeful time to even be living with MS. And together, through patient engagement, through research engagement, through comprehensive clinical care with our occupational therapists, our physical therapists, our speech therapists, we can roll that boulder up the mountain and change the way we treat MS. Thank you very much. We have a couple minutes for questions if anyone wants to. Right here. Do we have someone with a microphone? Coming right up behind you.
Regarding inflammation, how do we know what our level, do we have a lot of inflammation? Is there such a thing, inflammation? Is there such a thing as lesser amount of inflammation? How do we know?
Yeah, there are levels of inflammation. The gold standard in how we measure that currently is through MRIs. And that's part of the reason why, especially early on in the disease course, or if there's new symptoms we're investigating, we will get an MRI with and without contrast. That gadolinium contrast is a molecule that's too big to fit through the blood-brain barrier. So in a healthy brain, it just goes through your arteries, through your veins, back out through your kidneys, and you pee it out, and it doesn't do anything on the MRI. But if there's a break in the blood-brain barrier, that gadolinium leaks in, and it lights up really bright on the MRI. And so in MS, we interpret that as being active inflammation right now. We know that that only lasts about 8 weeks. So that's the gold standard in how we tell. There are blood tests now that are being marketed and researched for trying to measure levels of inflammation without having to get MRIs or in conjunction with MRIs. That has not necessarily become standard of care yet, and each individual doctor might have different opinions about the utility of that, so that those are kind of individual conversations as to whether it's worthwhile in your particular case to get those blood tests in addition to the MRIs. But yes, we can actually tell how much inflammation you have. And if someone's MRIs look exactly the same, we tend to think that there's less inflammation. If they're having new lesions or enhancing lesions, that's active inflammation. Right up front.
Hold on.
Dietary changes.
Yeah, so the question was about inflammation and diet. And there's a lot of things that are marketed in terms of anti-inflammatory diets and things like that. Full disclosure, my wife is a dietitian who has made a presentation about this in MS. So my opinion, formulated somewhat by that, is that eating healthy is a really good idea for everyone in this room, whether or not they have MS or not, right? And the more and more we know about diet in general, that eating food that is lots of fruits and vegetables, whole grains, lean meats and proteins, not a lot of high salt, high processed, high saturated fat, high sugar type foods is going to be good for you. The more and more we know about MS, we know that comorbidities like diabetes and high blood pressure may actually worsen the disease course in MS, and those diseases are directly modifiable by diet. So if you have one of those diseases that have high levels of evidence, you should be on a diet that treats that disease. If you only have MS, there are multiple diets that have shown some benefits in quality of life, specifically in things like fatigue or kind of happiness enjoyment, but there's no diet that has been shown to independently change the inflammatory markers in MS in terms of MRI outcomes or to change the long-term disability outcomes. And so there's no one specific diet I recommend for people living with MS if they don't have high blood pressure or diabetes or other things like that. But eating healthy is a good idea.
Thank you, Doctor, and thank you for all of this extensive information. My question, and I ask this at just about every conference I go to, and there's quite a few of them, the relationship between trauma and MS, whether it's an event or an exacerbation, and the treatment of that trauma, whether it is you stub your toe and you wind up it's broken, and something happens and you all of a sudden you don't feel good anymore, or you have a car crash, or in my case, I was fighting with 20-pound doors doing an ADA assessment, and I now have to have surgery. That too is a trauma. Not enough, in my opinion, and I'd like yours, is discussed about the relationship between trauma, which is stressful, and we know stress and MS are not good together, and how that relationship can be addressed and specified. Thank you.
Yeah, I think that's a great question, and great questions are generally stemmed from the fact that we don't have a lot of data, so I don't have a strong answer for you and a strong data for you. Obviously, when you use a generic term like trauma, and you mentioned different things like physical trauma as well as stress, those could be very different and would probably need to be studied separately. From the limited data that I'm aware of, we know that there is a link between reported stress in people with multiple sclerosis and their MRI activities. But necessarily how to treat that and what to do about that, I think is not entirely known.
Great. We have time for one more question.
Right here. Oh, okay. Sure.
I've been getting a lot of information on UV lights. Do you know anything about that? Ultraviolet light box for treating MS?
So I do not believe that ultraviolet light boxes are going to treat MS directly, with the exception of, we know that there are links to vitamin D deficiency and MS. And so I'm going to not directly address the light boxes, but I'll talk briefly about vitamin D. So we know that genetic risk factors of vitamin D deficiency are linked to risk factors of MS. We know that where you live in the world and how much sunlight is there is linked to MS. And we know that people who have MS have much lower levels of vitamin D. It's very controversial as to whether addressing vitamin D deficiency actually treats MS. Two large studies were recently resulted, one of them out of Australia, one of them out of France, and they had completely different answers. One of them said that vitamin D out of Australia did essentially nothing for people who had clinically isolated syndrome, and no dose made a difference. And the one out of France said high dose vitamin D, specifically in people with very low vitamin D deficiency, actually benefited them significantly. I can't help but notice the environmental differences between Australia and France in those two things. I think more data is needed to really tease that out. And so if you had vitamin D deficiency, I could see an argument where if you were fixing your vitamin D deficiency with sunlight exposure, and which would really probably be more true sunlight exposure rather than light boxes, that might be more beneficial, but we don't have any data to prove it. So I wouldn't make a strong recommendation at this point.
We have one more.
Hi, thanks. All of these studies referenced the blood-brain barrier and brain lesions. How does it apply to somebody that only has spinal lesions, or how do all of these studies apply to the spinal lesions versus brain lesions?
So if someone only has spinal lesions, that raises big questions about the diagnosis, but I won't address that specifically there, but because there are many diseases that can cause spinal cord lesions. There's many diseases that can cause brain lesions. There's not so many diseases that can cause brain and spinal cord lesions, so it becomes less of a slam dunk, and making sure you have the right diagnosis is important. But in terms of the involvement of spinal cord, we as clinicians know they're very important. The spinal cord is a very small area of the nervous system that carries all of the signals for walking, arm use, bowel bladder use, very, very important. And that's what included in some of our decision making. In the current kind of diagram of individualized care, we look at whether or not you have spinal cord lesions. And if you have spinal cord lesions, we're much more likely to put you directly on high efficacy therapy than not. So clinicians are very aware of this. The technology of MRIs in spinal cord is much lower quality and much lower consistency than brain MRIs. And so most of the clinical trials being run in MS actually don't include spinal cord MRI data. And so that's why these research papers are not necessarily talking about spinal cord, because they just don't have the consistency to include it. But the people listening in the back can hear how important spinal cord is, so maybe in the future clinical trials will include those. Okay, thank you so much.
All right, I want to introduce Dr. Desmond Bernstein, who's a physical therapist from the Barrow Neurological Institute here in Phoenix, Arizona. We're very excited to have her speak a bit about the importance of moving, and also to get us moving a little bit. So everybody welcome.
Good afternoon, almost lunchtime. Thanks for holding on with me. So today we're gonna go over a little bit of basic stretching 101, because that's one of the best things that you can do to just help yourself feel better in your everyday life. So let's just briefly, I gotta change slides for myself, sorry. So let's just briefly touch on why stretching matters. But first, do I have any stretchers in the room? Does anyone stretch? All right, like a decent amount of you. I noticed that all the ones I've worked with raised their hands, so thank you guys. So I hope to create some converts today. So let's start with why you should stretch. So when you're stretching regularly, you're just gonna feel better. The way that you're going to feel better is it helps to reduce muscle tension and promote relaxation. So those muscles that feel tight just will automatically feel a little looser because you're stretching them out. It can also help to prevent muscle strains. So when you're moving around and you feel like you've pulled that muscle, having a really tight muscle makes you more prone to getting injuries. Also, you can increase your range of motion at joints and improve your flexibility. So that's a fancy way of saying that you have enough motion in your joints to do whatever you need to. I may not be able to need to be able to do this, but it does help me to reach overhead to grab a high can from a shelf or something like that. It also improves your body awareness. It's helpful to improve your body awareness because if you are more aware of where you're tight, where you're not feeling good, one, it helps you to figure out how to move or what you need to do to make yourself feel better. And then if you can't make yourself feel better, that helps you to guide your practitioners, whether that's your primary care, your neurologist, your therapy team, to say, hey, this is what I'm feeling. So when you're more aware, you're a little bit more able to help yourself and to communicate. And it also helps promote healthy circulation. There's two types of circulation that stretching helps to achieve. One is circulation of the one that we all know, the system of blood going through our body. So we're getting blood into those muscles, we're bringing oxygen and nutrients in, and helping to get any latent like pain chemicals, that kind of stuff that can accumulate out of those muscles. So that can help you feel better. But also, fun dorky fact for the day, most of your joints don't have dedicated blood circulation to them. The way those joints get circulation is through movement. So by those bones moving around in that joint capsule, that is what provides nutrition to the joint. And by moving through that, and by providing nutrition both through the blood system, that circulatory system, and by stirring the fluid in those joints, that also helps you to feel better. Also, we always like to talk about posture as someone who's always working on it herself. By improving your posture, that's gonna help to prevent you from getting into positions that tend to provoke pain, especially as time continues on. And then of course, reducing tightness from just having those tight muscles. And so that's all of like the reasons to try to convince you, but also it just makes your daily life easier. So just on the base level, you can do tasks like reaching, bending over, grabbing. You can go easier to transition from positions, whether that's standing up out of a chair, whether that's rolling over in bed. And by being able to do all of those individual tasks, that helps you to put on clothing, helps you to reach down to get your toes to tie your shoes, helps you to reach and bend over when you're managing laundry. It's amazing how just feeling better and having flexibility can help you do things like prepare a meal, etc. And then, of course, we do need to talk about how to stretch safely because you can do it wrong. So static stretching is the stretch that we're going for. Static stretching means you go into a position, you hold it. A lot of people, when they stretch, they like to like bounce, do a bunch of like movements, and that's not actually the way that a muscle really wants to be stretched, especially a muscle that has high tone or spasticity. They don't like those bouncing movements. The best way to really get a good stretch is you want to get into a good posture, which is going to help to optimize the stretch that you're doing. You really just want to feel a comfortable pulling sensation or a gentle stretch, so like a gentle pull. And you really shouldn't feel pain with this. In part, you're not gonna be able to hold that position if it's painful for 20 to 60 seconds. And research shows that the longer you're able to hold a stretch, the more beneficial it's gonna be. You do wanna make sure you're breathing throughout. Breathing helps to really activate your rest and digest system. That's it's the opposite of the fight or flight system. So when you're breathing deeply, that's gonna help you to get a little bit deeper into that stretch. It doesn't mean you need to pull harder. It just means that you're enabling that muscle to relax a little bit better when you're able to get good breath. And then we do always recommend stretching daily. I know, having been sitting in talks across the street for the last 2 days, I go home and my husband's like, "What you doing, Des?" I'm like, "I'm getting out my yoga mat because I've been sitting all day." So I myself also have had to stretch daily to help me feel good as well. And then if you have really tight spastic muscles where for example, that classic is your toes like to point down and in, that kind of thing, then you might want to stretch more than once daily, because the more frequent you're going to stretch those muscles, that helps, and that really is one of your foundations of tone management. Last thing before we get to the part where you actually get to move and start to go through some foundational stretches are just some other tips to make you successful in your stretches. If you do take an anti-spasticity medication like baclofen or another one, when you feel like you're kind of at that peak benefit of that medication, that's a great time to sit down and do your stretches, just to enable you to get a little bit deeper into those positions. Also, just like I mentioned with that rest and digest system, go somewhere where you feel good. Go to a comfortable setting, somewhere that's quiet and not like dishes crashing around or something like that. Somewhere where you can really just relax and focus on your breath. And then finally, everyone's different. Everyone has some asymmetries in their body, whether you have MS or not. So some people just need a little bit of help finding what's really the best stretches for you and for the needs of your body. So today we're gonna go over some foundational basics to do. We're gonna hold for the 30 to 60 seconds. I have my trusty phone here. We'll do 30-second ones. Otherwise, stage time tends to crawl, I find. And then what you might wanna do is, if there's other stuff that tends to bother you, if you're like, "Oh, I have pain here or here," you might wanna talk to your provider, whether that's your primary care, your neurologist, about getting in to see a physical or an occupational therapist, because that's one of the foundational things that we do within our plans of care. We look at how mobile you are, and we identify like what could best help you for your everyday flexibility routine. So let's do it, friends. So we get it all stretched together, whether you're a caregiver, whether you're a patient, let's all do it, because everybody can really benefit from stretches. Hopefully I don't get feedback. Actually, I don't think I should get feedback. Alrighty, so the first one is the chin tuck. Now I already talked to you guys. Can you guys see me okay? I'll stand up for the not seated ones. So the first thing to do before we go into the chin tuck is pull yourself out of your forward posture. So think shoulders back, shoulders down, and then just grow as tall as you can through your head. Once you've done that, just tuck your chin lightly down to your chest. Don't fall down, okay? So by doing that chin tuck with shoulders down and back, you might start to feel a stretch through the front of your pecs. You should, if you are tight in the back portion of your neck, you can feel like some stretches through the back part of your skull, maybe your neck, maybe your upper back. I'll shut up for a few minutes and or a few seconds and let you breathe here as well. Okay, coming on up out of that one. We'll go on to our upper trapezius stretch. So we're still in that good posture. Shoulders down, shoulders back, you're tall. You're just gonna take your right ear, drop it towards your right shoulder, and you might feel a stretch right away through the left side neck. Now, if you feel like, oh, I could do a little bit more, I don't want you to pull, but if you have the ability, you can gently rest your hand on top of your head to just get you a little deeper stretch, and then just keep breathing here. These first 3 stretches, by the way, are really helpful if you kind of get stress headaches. Stretching these can help out. Good, bringing that head up. Then going the other way. So left ear is going down to your left shoulder. Make sure you're not bringing your shoulder to your ear. Make sure it's ear going to your shoulder. And then if you want to, you can add on a little extra. When you're breathing, think breathing nice and big in through your nose, really letting those ribs expand. And then you can breathe kind of gently out through the mouth. That's kind of the best way to really get into that yoga breathing. Good. Coming up, our next stretch that we have is called levator scapula stretch. This one's kind of like a little bit of an armpit sniffer. So we're in our good posture. You're going to turn your nose a little to the left, and then you drop your nose straight down towards your scapula. You should feel a stretch running from the base of your skull all the way down to your shoulder blade. If you need a little bit more, you can rest your hand on top of your head. Good. Coming on up. Other side. So taking our nose about halfway to the right, dropping down towards our armpit, and then taking some good deep breaths. Check how your deodorant's doing today. Make sure you're still sitting tall. Make sure you're still in that good posture, please. Good, coming on up out of that one. We're gonna go into our chest next. So we're gonna do one peck at a time. You can opt to just do this, but to really get into one peck at a time, you can kind of rotate in your chair. You can hook your kind of mid-arm or your elbow onto the chair so you can kind of rotate. Okay, please don't fall off the stage shelf. So you can kind of do that, and then you can really feel a good pull coming through. This is one where you want to make sure you're not shrugging up into your ear here. This is one where if you feel like tingles in your hands, you can just kind of do a little less too. Sometimes less is more. All right, switching sides. You're gonna go on to that other chair, and you're gonna hold that arm out. You should be feeling that stretch through the front of your pec, right towards the armpit there. Alrighty, moving on, we've going on a little down those arms. We're gonna go into wrist flexor stretch now. So you take your hand, palm is up, forearm is up towards the ceiling. You kind of lever all four of your fingers and you pull, and you should feel a nice gentle pulling through the front of your arm. This is one where we like to close our chest up. So make sure those shoulders are still rolled open here, please. This is great for people that type all day because we're here all day, so it's good to stretch out. I don't know about you, but I gotta shake it out a little bit. Now let's do that other side. So wrap all 4 of those fingers. Make sure your shoulder's down out of your ear. Nice, good stretch here. Still using that good deep breathing in through the nose, out through the mouth. Good, little shake here. All right, going into some of our trunk stretches. Alrighty, so if you're in a wheelchair, you can kind of use the arm of your chair and you kind of take your elbow down to the chair, or else you can just kind of go down to the side and you can just go up and reach all the way to the side. Now, some of you might be like, ugh, that feels gross, or my shoulder doesn't do that. If that's the case, you're just gonna reach kind of across your body for this. So choose which one feels good for you and think about really sending that air into the ribs, if it's your right hand that's overhead, into those right ribs that are kind of right under your armpits. Good, come on up tall. Take a moment, just open those shoulder blades before you go over, and you can go over, or a little twisty. Sending air this time into the back of your left ribs. Good, come up tall. We're gonna do a quick rotation. We didn't have a slide for this one, so you're just gonna have to trust in your demo person up here. So for rotation stretch, we're gonna wring out those ribs a little bit. So you're gonna rotate to the left. Maybe your arm is able to hook over the chair, and then you just take your right arm, move it to the side. So you're just twisting. Most of this is really occurring in your upper spine. Think about growing a little taller with every breath. And then exhale and just relax. Good. Back to center, and we gotta, if you go to the right or the left, you definitely gotta go right. So hook that arm over the chair, reach left arm as far across your body as you're able to, and just breathe and enjoy that spinal stretch. Okay, back to center, and then should just have 2 last ones. So we've got hamstring and calf stretch. I don't know about you guys, but I don't roll around with a pillowcase or sheet. So we're gonna just do our best, okay? This is a really good one when you're at home. If you're someone who's like a wheelchair user, I have a wonderful army of Barrows therapists back there. So if you need a little bit of help finding this stretch, you can kind of raise your hand. We're just gonna do the hamstring stretch for today, okay? So what you're gonna do is you gotta scooch to the front of your chair. So get that booty close to the front of your chair. That's really the secret, because then when you straighten out with your toe up towards the ceiling, you might feel a stretch automatically right behind your thigh. If you don't feel a stretch behind your thigh, you can start to hinge forwards until you feel that gentle stretch. Maybe you want to just rest your elbow. If you're a dude, a lot of times this is plenty for you. Good, couple deep breaths. So hamstrings are one that tends to be spastic for a lot of people. So hamstring stretch can be really good. I'll just touch on that calf stretch. To really get to the calf stretch, what you need is a towel to hook over the top of your toes so you can pull toes back towards your nose, which will allow you to get towards the calf. All right, quick switch. Let's get that left hamstring or other side if you don't adhere to left and right. Think about toes straight up towards the ceiling, pulling toes back towards your nose, trying not to just go out of good posture while you're doing this. Good. And last one, the problem with moving is I lose my stuff. All right, let's just finish with the hip stretches here. Come on. It's not going forwards. Yeah. Can you hit the button better than me? While she's trying to fix it, I'll just demo too. All righty. Right ankle crosses over left knee. Now maybe you already feel a stretch in the outside of your hip, groin, something. Okay, the first thing you can kind of do to check where you want to stretch is you can take your left leg and you can kind of wiggle it right and left. See how that feels, and if there's like a good stretch there, maybe not. Next thing you can do is you can hook hands under your knee, pull it towards your opposite shoulder. Some people say, ooh, that's a real stretch. Some people feel better if they push their knee away. Everyone's a little different. So find that spot that's like your spot. And then just breathe. Switching, last one we're gonna do before, I'm almost this is the last thing between one more thing before lunch, friends. So left ankle over opposite knee. Same little thing, take that moment, go a little side to side. Everyone's a little bit different, and right and left. Try up, try down, see which one works for you. And while you're finishing out that stretch, because I went like 2 minutes over, I'm gonna start to sneak away from the stage. Thank you for your time, and I hope I have turned some of you into stretching converts. Anyone want to stretch after this? A couple of you? All right, yay, thank you guys.
Thank you so much. What a great way to put a little exercise into the middle of our day. So thank you for that. Good afternoon, everyone. My name is Laura Allen, and I'm the AVP of Operations at Can Do MS. I'd like to begin by thanking all of our exhibitors for joining us at our More About MS program. Your presence and support is truly appreciated. A special thank you goes out to all of our pharmaceutical partners for your ongoing commitment to advancing MS care. Your collaboration plays a vital role in improving the outcomes and helping families living with MS thrive. I'd also like to extend a special thank you to Novartis, TG Therapeutics, and Sanofi, and invite representatives from each of these companies to say a few words. I would ask if you have any questions to direct them to the exhibitors. First up today is Allison Handler, a pharmacist from Novartis, and she is the Director of Patient Advocacy and Neuroscience. Welcome, Allison.
Hello, everyone. I think I could still say good morning, even though we're very close to afternoon. And I'm from New Jersey, so it's actually afternoon for me. I'll try to keep my remarks brief because I know we're between you and lunch. So we want to, and now you're all relaxed too. So as you heard, my name is Allison Handler, and I am the Director of Patient Advocacy, which means I get the immense privilege to work with patient organizations and communities in the MS space. And it is one of the best jobs, I feel like, in pharmaceutical industry to be able to do that. And it's my absolute pleasure to be here with you today. And first, what I really would like to do is just make sure you give yourselves a round of applause for creating this time to invest in yourselves, to come here and learn and grow, and how you can, as Laura said, thrive. So just take a moment to give yourselves a round of applause for doing that. And I also do want to congratulate the Can Do MS team, all of them that made it, for organizing this event. It's always a heavy lift to bring something like this together, but more so their ongoing commitment to providing this informative programming. And we're, along with my other counterparts, are really proud to contribute to sponsor these types of community programs that bring you here today. My colleagues and I really do appreciate this opportunity to continue to work alongside this incredible organization with our shared commitment to sort of improving and providing meaningful impact to those living with or impacted by MS. Not only do we support these community programs like the More About MS program, but we continue to support amazing other programming, such as the Take Charge program, that if you're not familiar with, this virtual wellness program provides their most in-depth program offerings around 3-4-week coaching sessions, quarterly meetups with the Black community, as well as other monthly virtual meetups. And what we love and what I love about this program is that it's truly intentionally designed to help those living with MS and care partners to create and set goals around so many different aspects of your MS care that will hopefully help improve nutrition goals, physical, emotional health, as well as cognitive and self-advocacy. So if you're not aware of those things, we highly encourage you and look to continue supporting those. And new this year, we were able to collaborate with Can Do MS to make sure that we could launch a new programming called the Make Your Voice Count collaboration or initiative. And this provides a community for those that are newly diagnosed with MS, and what we're also finding, some that are kind of new to re-engaging in the MS community, that provides a kind of a comprehensive way of engaging, whether it be through some virtual monthly meetups, through some podcasts, through short form videos, and even on your table, you'll find a little bit of a new info guide that provides some really basic, back to basic information, but space to ask questions and engage and meet others like yourselves to just get more information around MS. And we're really excited to have launched this program and continue to see where it will evolve and get engagement with other healthcare providers as well to help you again along the MS journey. Finally, I just would like to say my sincere appreciation to Laura Allen, who you just met, as well as Kathy, who opened up the program, for their ongoing leadership, expertise, and really innovative thinking in bringing programming like this to the community. The insights that they also bring back from what they hear from all of you is what we take to heart and want to use and bring back to those internally at Novartis so that we can bring things and, it helps inform our strategies and some of our materials that we're bringing out to the community as well. So I continue very passionate about working with organizations like Can Do MS and other like-minded that are all around the room here to be able to bring programming and resources. And I really remain excited for what's ahead. As you heard, I'm a pharmacist, but I also serve as a caregiver to my father who lives with Parkinson's disease and a support partner for a very close friend who has MS. So I feel like when you find that alignment of passion between personal and professional, it really just ignites what we continue to do with a purpose. So I hope everybody enjoys your afternoon of workshops and continued learning, and I look forward to maybe seeing you guys. Please visit our table. My associates that are here, happy to engage and talk to you about more of what Novartis does and the products that we bring to serve the MS community and answer any questions that you might have. And maybe we'll see you during the afternoon happy hour kind of networking session. So thank you so much for your time.
Allison, thank you so much, and thank you for the support of you and Novartis. Next up, I'd like to introduce Dr. Ed Fox. Dr. Ed Fox is with TG Therapeutics, and he is the National Physician Liaison and Vice President. So Dr. Fox, welcome.
Thank you, and happy International MS Day. It has been a great meeting down the street from here at the Consortium of MS Centers. I've been going to it for many years. I became a neurologist in 1992, which is the year before the very first MS medicine was FDA approved, which means for my entire career I've been able to say I remember when. But the number of medications that have been launched in MS has been really quite remarkable, and I was involved in a lot of clinical research, and that's what I'm doing now with TG Therapeutics as well. It's a small company. When something starts out and has one product for one disease state, as we have with TG Therapeutics, it can start small. So 300 employees right now, 3 medicines under development, and 40 ongoing clinical trials, each one of which is looking at different aspects of MS or other autoimmune disease. And so that takes a lot of people, volunteers for these clinical research trials, over 3,000 people. And, certainly every company has many people to thank for being participants in clinical research trials. The one goal, though, for each and every one of us that deal in the MS space is to fully control the disease in all aspects. I come to a meeting like this and I learn so much, and hearing previous speakers talking about remyelination and everything else. Yes, that's the areas of research that we're all interested in right now. And so now that we have, we are the latest medicine to have been FDA approved for MS, but by no means the last. Briumvi has been, in over 10,000 people, and many healthcare providers have prescribed it at this point. And so, where do we go from here? Well, I can tell you at the CMSC meeting, every single year, more attendees, more variety of people that are attending, and you walk through the exhibit hall, and this is very impressive, the number of sponsors that you have here. But the number of companies that are involved, not just in medications, but in products to try to improve people's lives, technology at play here. It's a very exciting time, continues to be exciting, and it's been an honor to see this kind of event be linked to the CMSC. It's a constant reminder to everyone down the street what we're here for. So thank you very much for the invitation. Thank you for the sponsors and planners for the meeting as well.
Dr. Fox, thank you. Perfect. Next, I'd like to thank our presenting sponsor, Sanofi, and welcome to the stage Tyson Iddings, Senior Director of Consumer Marketing. Welcome, Tyson.
Thank you. First, want to start with thanking Can Do MS for the kind invitation to be here with this incredible community. We're deeply grateful for your partnership and for all that you do for empowering patients throughout the community and for their loved ones. At Sanofi, we're proud to collaborate with the MS community every day, driving progress and innovation. We understand MS is not just a clinical condition, it's a person. Unpredictable journey, one in which your resilience and strength inspires us each and every day. And being here this week surrounded by all this emerging science at CMSC, we're energized about the future of MS care. But we also recognize that beyond each data point is a real person, a family member. And the goal of all of this science is to improve people's lives. And while I'm not here to discuss specific therapies, our work in MS continues to grow. We're continued and committed to advancing how we identify and monitor disability progression, knowing that this is critical for people living with MS and their families. And we know that education plays a key role in empowerment. That's why we developed Rediscover MS, a resource to help patients understand disability progression and help them engage and feel empowered to confidently have these conversations with their care teams. And furthermore, this summer, we'll host hundreds of live events that will be in person across the United States to really help support those living with MS and their care partners and help educate them on the different processes of MS. And if you haven't had a chance recently to go to rediscoverms.com, I would urge you to go check out the site and all that's been done as of recently. In closing, a special thank you to Can Do MS and to all of you for your unwavering dedication, for everything you do to support one another. We're honored to be a part of this journey with you, and we're excited for what's ahead. Thank you.
Thank you, Tyson.